Hello, I'm Mark Melin. I'm a wound care surgeon as part of the University of Minnesota in Minneapolis, Minnesota, and I'm going to be discussing lymphedema of venous etiology and spaceflight neuro-ocular syndrome, environments, the endothelial glycocalyx, genetics, and common nutrients. I have no disclosures. So as Dr. Kerwin, who's one of the first physicians to enter low Earth orbit as an American physician, stated, exploration medicine is understanding and dealing with normal humans in abnormal environments. In our clinic, we deal very commonly with lymphedema, which impacts venous insufficiency, diabetic foot ulcers, and severe peripheral arterial disease. There are two emerging chapters in medicine within the microcirculation. One involves the evolving knowledge regarding the microvascular endothelial glycocalyx and the lymphatics and the lymphatic endothelial glycocalyx, and lymphatics are markedly undertaught within medical education. This classic 1996 study demonstrated a significant headward shift of body fluid that's estimated to be approximately 1 liter from each leg within 6 to 10 hours of reaching low Earth orbit. Plasma volume and extracellular fluid volume are also noted to be decreased, and this is approximately 17% with regards to plasma volume. And it was noted even back in 1996 that there's an increased permeability of capillary membranes that may be the most important mechanism causing spaceflight-induced plasma volume reduction, though the clear mechanism of action remains under discussion. With regards to lymphatic function, Guyton's hypothesis, which was proposed by Arthur Guyton in 1971, was recently proven in 2017 by a group from Texas A&M as well as from the University of Missouri and Columbia, Missouri. And this demonstrated that there is a subatmospheric component to the lymphatics in the lower extremities that acts as a sucking mechanism to move lymphatic fluid from the toes to the knees to the legs along the ventral medial bundle into the iliacs and then to the thoracic duct where it empties into the subclavian veins. So the naturally primed subatmospheric system throughout the density of the lymphatics within the lower extremities that contributes to this distal proximal motion. And this is clearly demonstrated in this cartoon where we can see the lymphatics, which are extensive and well underrepresented in this picture. Ultimately, everything below the subclavian vein level is dependent upon Guyton's hypothesis. However, the head and neck are primarily dependent upon gravity to assist in drainage, both the lymphatics as well as the venous components. In this demonstration of a lymphangion, which is measured from valve to valve, there is significant motocentricity within the lymphatic endothelial component and within the adventitia of the lymphatics to ensure pumping from distal to proximal. Dr. Sant'Ambrogio from Weill Cornell now is one of the first people to talk about the endothelial glycocalyx within lymphangions in the lymphatic distributions. The old Starling curve from 1896 demonstrated and discussed the fact that of all of the interstitial fluid that leaves arteries, approximately 80% would re-enter veins. Due to the presence of the glycocalyx, which is a permeability barrier, we now know that when the interstitial fluid leaves the arteries, only 5 or 10% actually re-enters veins, and 80 to 90% of the fluid actually enters then into the lymphatics. With this recognition of the glycocalyx contributing to lack of ability of fluid to re-enter the veins, has created a renaissance of research into the lymphatics, given now their understood significant importance both in interstitial fluid management as well as their significant contribution to the understanding of immune function within humans as well as all organisms. The surface area of the microcirculation is vast. It's estimated there's 50 to 60,000 miles of vascular and lymphatic length to the 5 micron level, 5 microns being 1/3 the size of the human hair typically being approximately 17 microns in size. And it is across this 5 micron level where all nutrient and oxygen delivery occurs. This is also where the microvasculature is so significant in terms of contributing to nitric oxide, specifically endothelial nitric oxide production, which results in vasodilatation, lymphangion contractility, and helps in terms of immune functioning of the body. So we know that in chronic disease states where there's chronic inflammation, such as diabetes, patients on dialysis, hypertension, hyperlipidemia, tobacco use, severe obesity, venous hypertensive disease, autoimmune diseases, advanced lymphedema, that these are chronic inflammaging clinical states that are resulting in decreased endothelial nitric oxide production. In addition to the loss of endothelial nitric oxide production, there's also a decrease in cofactor BH4, which then results in even less ability to handle reactive oxygen species, resulting in premature development of cardiovascular disease. So the recoupling of endothelial nitric oxide synthetase is critical to maintaining endothelial nitric oxide production. And part of this now is well recognized to be the functional status of genetics and epigenetics with one carbon methylation. So in patients specifically who have a single nucleotide polymorphism, say of MTHFR abnormality, such as a heterozygous or homozygous state, they may not be able to respond under times of inflammation or stress to produce adequate endothelial nitric oxide, resulting in deficiencies that can result in impairment of microcirculatory function. These states can be adequately treated oftentimes simply with B12, folate, and B6, and can then improve vasodilatation and immune function. And this is going to occur both at the macro level as well as the microvascular status. This is demonstrated in Dr. Zwart et al.'s publication. This was actually related to astronaut ophthalmic syndrome before it was renamed Spaceflight Associated Neuro-ocular Syndrome, or SANS. And this again demonstrates at the 5-micron level that when there are genetic abnormalities resulting in uncoupling of endothelial nitric oxide synthetase, that you have increased oxidative stress, increased fluid leakage, and then lack of vascular relaxation. As an introduction to the glycocalyx, which may be a new phrase for many of you, think of it as functional ontology. So from a computer standpoint, a computer has hardware, software, and a power source. The endothelial glycocalyx has hardware, which consists of its prime components of glycoproteins, proteoglycans, glycosaminoglycans, caveolins, and then micronutrients that help this to function properly. Then there's the software component made up of genetics, epigenetics, methylation, single nucleotide polymorphisms. And then you need a power source, which is then going to be shear, and that's oftentimes oscillatory shear. So movement back and forth, specifically in that 5-micron level, that results in mechanical transduction or changes from a mechanical standpoint of the changing or waving back and forth of the glycocalyx that then impacts endothelial cell function. So in this microgram, you can see the glycocalyx is represented in this, and look at the scale, 1 micron. So this is about a 5-micron vessel, and the hair-like components are the complexity of the glycocalyx. This is like an Amazonian forest in terms of layers and in terms of complexity. So the role of the healthy glycocalyx, and in the acronym to remember is EPIC. So there's endothelial cell function, which significantly results in endothelial cell nitric oxide production, as well as potentially other cytokines. The P is permeability, so much like a Gore-Tex layer, once interstitial fluid exits, it cannot come back in. It's a coagulation barrier, so the C, coagulation, so it inhibits platelet adherence, as well as it covers up coagulation factors. So when there's shedding of the glycocalyx, it exposes these coagulation factors. There's a much higher risk of then developing micro or macro thrombi. And then the I in the EPIC, so EPIC, the I is inflammation. So this quenches diffusely in terms of management of states of inflammation. Now, in this 2021 study that talks specifically about the glycocalyx and caveolae in terms of vascular homeostasis and disease, you can see that in the non-pathological state, shear stress results in stimulation of the syndicans, the heparan sulfate, and the glypicans, And this then results in coupling of endothelial nitric oxide synthetase. The importance about coupling is that it increases nitric oxide production, which has the cardiovascular protection components that we discussed. This also then quenches reactive oxygen species so that there's full functioning of the antioxidant system. Now, in pathological states where you have shedding the glycocalyx, such as smoking, diabetes, hyperglycemia, hyperlipidemia, venous hypertension, arterial hypertension, trauma, sepsis, this all results in microvascular uncoupling of the endothelial nitric oxide synthetase production system. So not only do we have loss of nitric oxide production, which negatively impacts cardiovascular conditioning, it also results in increased reactive oxygen species, so a dysfunction of the antioxidant system. This then results in breakdown of elastic tissues, collagen, etc., so that we have things like arterial stiffness and other downhill stream effects that we see with cardiovascular disease. So this is just demonstrating, again, shed of the glycocalyx exposes the endothelial cells. We have increased leakage of macromolecules. We have decreased production of nitric oxide availability. We have increased platelet adherence and increased white blood cell adherence. Now, typically the glycocalyx takes about 7 days to restore itself. So when hyaluronidase or heparinase, both enzymes that degrade the glycocalyx, we can see that between day 0, where we lose the glycocalyx, and restoration typically is around day 7, which we typically see clinically in patients that have sepsis, and as they recover from the offending infectious agent, we see that they start to diurese, the interstitial fluid goes away, and that they start to recover organ function. So this is a typical example of what we see in our wound clinic, where there's uncontrolled interstitial edema. Now, this results in rarefaction, meaning that those 5-micron vessels are so compressed by the significant degree of the interstitial edema that they cannot perfuse and cannot function. So here we have loss then of oxygen and nutrient delivery, which ultimately over the long period of time can result in ulceration. So think of it as a flooded farm field. There can't be delivery of oxygen, there can't be the delivery of nutrients, and there's going to be loss of the plants in this field. This is the same thing in chronic interstitial edema or lymphedema, where we result in decreased microvascular perfusion that results in increased oxidative stress. And here's a perfect example. This is a patient that we've had in our clinic for a long time that I've been dealing with. Chronic primary hereditary lymphedema resulting in rarefaction, causing interstitial fluid increase that results in microvascular compromise, causing relative tissue ischemia. So even though his macrovasculature, so his dorsalis pedis, posterior tibial arteries, are all fine, the microvascular perfusion at the 5-micron level is compromised, resulting in these ulcerations and significant lymphuria or interstitial drainage, interstitial fluid drainage from these ulcerations. Now, patients that have MTHFR polymorphisms, and this is just one of many different SNPs, so single nucleotide polymorphisms. There's many of these that are potentially impacting overall health. So this results in ineffective 1-carbon metabolism and genetic influences on the glycocalyx, as we just demonstrated. This is present in approximately peer-reviewed literature, 20 to 40% of hard-to-heal venous ulcers. And it's treatable with simple common micronutrients like B12, folate, B6, because then this helps to make the gears of that pathway again to work to produce endothelial nitric oxide. Now, in our clinic, we also routinely add in micronized purified flavonoid fractions, given the impact on improving venous tone, lymphatic contractility, and decreasing ICAM, VCAM, and VEGF. Now, this specific flavonoid is called hesperidin diosmin. This is the one that's got the best peer-reviewed literature. It comes from a citrus plant. We also add in vitamin D3. We add in vitamin C as an antioxidant. If patients have been on steroids, we add in 10 days of vitamin A. We try to get all soda stopped just because of the phosphorus and the sugar component. Obviously, tobacco cessation is an important part. We favor Mediterranean-style diets because, again, this maximizes bioflavonoids and maximizes the components that help with the microbiome, specifically in terms of fiber. Emphasize nutrition. We stop Norvasc and amlodipine because this has a significant contribution to causing edema. And then diuretics clearly do not work for isolated lymphedema alone unless there's right-sided heart failure, renal, hepatic, or pulmonary dysfunction. So here's a typical case within our wound clinic where we have necrotic tendon, we have extensive microbiome disruption within the skin, and through the course of these 6 months of treating this patient, by doing so I took him to surgery, did extensive surgical debridement, did a single skin graft after adequate wound bed prep. We did certified lymphedema therapy management, got him into an advanced pneumatic compression device, and then we added in the micronutrients we talked about. So B12, B6, folate, vitamin D, vitamin C, and the flavonoids, specifically the hesperidin diosmin. And you can see the significant dermal restoration and regeneration in this particular patient. Now, remains at high risk for recidivism rate, but again, treating these in this basis, and you can see that when we do this consistently with patients who can adhere to a treatment program, we can get pretty good outcomes in about 70% of patients. So we actually looked at our retrospective study of patients with MTHFR. We were able to look at 88 patients. We just presented this at the American Venous and Lymphatic Society meeting in Denver about a month ago. And these are my colleagues in our wound clinic that helped produce this. And so really this was to look at how does MTHFR impact our patient population. Again, we're looking at a very isolated single nucleotide polymorphism. Well reported in literature that MTHFR polymorphisms can impact patients with venous hypertension and venous disease. Now, this also correlates with Dr. Zwart, Smith, Laurie, and this is the JAM ophthalmology report that looked at Spaceflight Associated Neuro-ocular Syndrome spaceflight analog with head down tilt increasing CO2 content, and then specifically looking at I think they looked at a total of 5 SNPs or single nucleotide polymorphisms, and found that this study suggested that genetic variants associated with folate status and function are associated with development of optic disc edema during the spaceflight analog of head down tilt with in an increased carbon dioxide exposure environment. Now, this is our patient population. It's a different fluid shift because in weightlessness, the fluid shift to the head, neck, and the upper torso causes significant interstitial edema, but it's causing the same components at the microvascular level that we see in the 1G environment in our patients where we have significant lower extremity edema development. So we looked at our patients. Again, it was typically 20 to 40% in a normal. What we found in our patient population is that 52% of patients were identified to have an MTHFR polymorphism. Again, this is a single SNP. Now, so this is much higher than the normal ambulatory patient population, but that makes sense because these are the patients that are having a very difficult time healing. You can see these patients have had these wounds for quite a long time, and by adding in the regime of B12, B6, folate, the micronized purified flavonoid fractions, the Ds and the Cs, in conjunction with good standard of care venous leg ulcer management with compression, we were able to normalize the heterozygotes to the patients that had wild type or normal SNP status. Now the homozygotes still are healing at a slower rate. Now this did not reach clinically or statistically significant status, but there was a clinical trend to improvement. This is clearly a very narrow focused study. It needs to be repeated in a much larger population, and then needs to be done in a prospective fashion instead of a retrospective fashion like we accomplished. Now clearly we do know that the endothelial glycocalyx is degraded in venous hypertension. And so again, when you look at the quality of the glycocalyx, it's like a lawn. And think of wind coming across there and waving the strands of grass. Now, when you see shedding of the glycocalyx, and think of this, it's almost like dryer lint within your dryer. So you can see the glycocalyx in here stained with lanthanum, and then without lanthanum, you can see that regular staining techniques cause the glycocalyx to be absent or lost. So this is one of the components of why it's taken so long in terms of medical history to identify the endothelial glycocalyx, because without proper staining techniques, and some of them can even be a fast freeze for preservation, but without proper techniques, you will lose the glycocalyx, and that's one of the reasons it's been not well understood until just within the past 10 to 15 years. So when you lose the glycocalyx, you end up with spots in your endothelium that are bare. And just like dry ground, it tends to crack, it's not functional, and becomes less able to support that health. And eventually, if you have severe loss of glycocalyx, it's like being in a desert, which has all the negative untoward effects. Now, the glycocalyx is actually variable thickness depending on which organ you're looking at. So if you're looking at the brain, in the blood-brain barrier or the blood-retinal barrier, it is the thickest in these areas, which makes sense from an ontological standpoint and a teleological standpoint, because if you're going to preserve one of the most important components of being a human, it's your brain. So it's thickest in the brain. Interestingly enough, it's thinnest in the lungs. Now, if you think about where we're at in the pandemic, Dr. Vink and his colleagues in Amsterdam have used glycocheck to demonstrate that shedding of the glycocalyx does occur in patients that get quite ill with COVID. And one of the portals of entry, of course, is the lungs, where the glycocalyx is the thinnest. So again, if you look at brain-specific ultrastructural capillary endothelial glycocalyx and its possible contribution to blood-brain barrier, it's now been proven that the glycocalyx is a significant component of that three-layer component of the blood-brain barrier, which is interesting. And I'm not proposing cause and correlation. This clearly needs a significant amount of more research. But when you look at crew members' white cell or white cerebral matter after deorbit. Now, this study was done, I think, looking up to 6 months out after deorbit, and one of the findings was we identified that no one has really identified before, is that there's significant increase in volume in the brain's white matter from pre-flight to post-flight. The white matter expansion, in fact, is responsible for the large increase in combined brain and cerebral spinal fluid volumes post-flight. So clearly there's an intracellular compartment fluid shift, and it's a matter of trying to figure out, why is this happening at the microvascular level? Now, the brain obviously is incredibly complex compared to the foot ankles that I'm dealing with in venous hypertension. So I think it's really important not to introduce hyperbole in here and to introduce too much conjecture. The science has to be done to determine what is going on specifically at the microvascular level in brains. Now, when you look at Jeff Illig and when you look at Macon Niedergaard, they've about I think 2011 they started talking about something that's called the G lymphatic system. Now, the G lymphatic system is not quite an organized lymphatic system like the rest of the body, but it helps to function in terms of sweeping mechanisms to clear the brain of things like beta amyloid, tau amyloid, etc. So it functions best during supine sleeping at night, and it sweeps the brain down along the cervical chains and the jugular components. Now, interestingly enough, there's also now been identified a G lymphatic component to the optic nerve. And when you start to look at the anterior chamber, the posterior chamber of the eye, and then look at the flow patterns for specifically the G lymphatic system, and I think this is incredibly complex, and I can't do it justice in this talk, but starting to put together all this data may help us understand exactly what's going on in SANS, in weightlessness with astronauts related to fluid shifts, specifically then if you look at the multi-hit theory, where then you start to bring in radiation exposure, increased CO2, and then certainly the single nucleotide polymorphism abnormalities that you can see among crew, where clearly they've shown that if you have a single nucleotide polymorphism, you are at higher risk for developing symptoms of SANS. So again, back to Dr. Dwarf's study et al., demonstrating again that in low Earth orbit, development of fluid shifts, increased insulin resistance, increased arterial stiffness, radiation exposure, CO2, and then you can start to look at some of the other endocrine changes that occur, such as early on with atrial natriuretic peptide increases initially with right atrial distension related to the initial changes in the 4 to 6 hours of reaching low Earth orbit. And then once you combine that with the genetic components, you can start to see how the multi-hit theory fits together in terms of resulting then in fluid leakage and microvascular permeability. This translates into, so this is a spin-off into how we are now looking at our patients in our wound clinics from a different aspect, and really where I think we focused on macrovascular disease before for treating patients with venous leg ulcers. This has really changed our focus to thinking about the microvasculature, which has a much larger component in terms of surface area in the legs. So looking specifically then at that 2021 paper, and thinking again about shear stress and thinking about the glypicans and the syndicans and the heparan sulfate components, if shear stress is altered in weightlessness, how does this impact the glycocalyx? And we don't know the answer yet because this is an area of ripe opportunity for study in terms of crew in low Earth orbit, and especially from launch to the time of landing. Now, the microgravity, there has been some studies that demonstrated decreases in endothelial nitric oxide synthetase and caveolae, and this was a study produced in 2018 to look at this. So, and when you look at this level, and this is figure 11, you can start to kind of incorporate where that microvascular endothelial glycocalyx would be that might be changed by weightlessness, shear force changes. Again, this is very hypothetical. It has to be proven. We need data and exploration in terms of this. And then NASA, with their vessel generation analysis, has shown some significant changes. Small n, few astronauts that had met the criteria for SANS, where there was actually loss in terms of the small vessel density in the retina. So again, these are all single data points, and I think we have to be very careful about simply linking all these together without excellence in science, excellence in data, to start to try to figure out, are these links true, and related? Because I think guessing about this is only going to get us, it is potentially lose what truly is going on. So this is going to require really good scientists, really good data, incredibly intelligent people to start to put this all together. So I have a lot of questions, and I think sometimes the most important thing we can do is pose questions. What happens in that first 23 hours after launch? How does increased ANP, which we know from the Leach paper, how does increased atrial natriuretic peptide impact glycocalyx? Because we know that ANP results in shedding of glycocalyx, and how then does this impact endothelial cell function, and specifically at that microvascular level? And then when we look at chronicity in flight, 24 hours to 6 months, the radiation impact, the chronic fluid compartment redistribution, the disruption circadian rhythm, which can correlate with G lymphatic changes, and then getting back to just simply looking at overall lymphatic changes, which we know has an impact on immune function, and we know that there are some, just that recent saliva cytokine study that was released in some of the changes. So we can start to see that with the microbiome changes, the genetic, epigenetic, the variances that occur, it potentially all starts to link together, but it needs good, hard science and data. And then once during D-orbit, is orthostatic hypotension somehow also related to glycocalyx thinning or shedding, which would cause hyperpermeability, which would relate back to decreased systemic vascular resistance, which is known to occur. So the multi-hit theory, especially with the genetic and the epigenetic adaptability, all this has to look at. Again, it's been a significant spin-off for our wound clinic. Final slide. The Handbook of Venous and Lymphatic Disorders, which was published by editor Peter Glowicki, who I actually trained under, phenomenal surgeon and just a world-class diplomat and ambassador. And with his wife Monica Glowicki and Dr. Dalsing and Dr. Eckhoff and Dr. Fedor Lurie and Dr. Wakefield, this is our go-to book about venous and lymphatic disorders. And obviously, Dr. Barrett's and Baker's and Dr. Poole, who obviously has passed away, this is the principles of clinical medicine for spaceflight, and is really the clinical guide for how we understand what's going on in low Earth orbit. The 2017 book that was published does not talk about the glycocalyx and lymphatics and venous, and the 2019 paper, or 2019 Principles of Clinical Medicine and Spaceflight, doesn't have a chapter about lymphatics and doesn't have a chapter about the glycocalyx. I think that's going to change because I think these are great opportunities for us to learn further about crew health in weightlessness, and the spin-off potential to demographic health is quite significant. I want to thank the organizers of the Australian Space Biology Conference for the opportunity to present this hypothetical and data point driven component. There's a lot of data that we have to look at, and it's been a sheer pleasure and opportunity to participate.